I have the pleasure to introduce Eric Cornut. Eric Cornut is head of the Novartis Europe. He is also responsible for Novartis global strategy, and he played a key role when Novartis merged with Ciba-Geigy in the 90s. He has been CEO of the Novartis Netherlands and CEO of Novartis France, and he holds a degree of the University of Basel and of Berkeley in California. So he will now tell us how shareholders of the treatment development can cooperate in order to realize the opportunities we do have in medical development. Thank you, Eric, for coming.
Thank you very much, and congratulations to the event. Ladies and gentlemen, rest assured I have no slides. I would like to share a dream with you that if we progress the same way in the next 50 years than we've done in the last 50 years, we will probably be able to cure many forms of Alzheimer. We will be seeing a world that has enough resources for healthcare because we will have injected efficiency in all of this. So in essence, let me share with you a few ideas about capturing the promise of scientific, technological, and economic progress to improve outcomes for patients, populations, and society. I dare to say that we live in a time of paradox in healthcare. The future seems very bright. That's the glass half full. We live in an area of scientific revolution in the area of life science, a technological revolution in information management, and even though I know in Europe it doesn't always look like it, an unprecedented time of economic progress. Let me share a couple of observations about the revolution in health science and speak about the ability to sequence the human genome. 10 years ago, one full genome every 10 or so years. Today, with next generation sequencing, one a day. The price has fallen from 10 million per genome in 2007 to 10,000 today, and keeps falling. It opens the door to more evidence-based medicine and more personalized medicine that will allow us to be more effective with fewer side effects for the immediate benefit of patients. The revolution in information technologies. Information technology, internet, gives today healthcare providers everywhere access to the latest guidelines. It allows, as an example, rural nursing stations in Africa to better manage their inventory and avoid stockouts of essential products. Crowdsourcing allows Google to produce daily estimates of flu activity to help public health officials predict and respond to epidemics. And finally, economic growth means more people will have financial access to healthcare. Laurie was very explicit about that. I don't need to repeat that. The potential benefits for health and economic well-being are tremendous. For example, a healthier, more independent elderly population, given the demographic and aging challenges that much of the world faces. In Germany today, average life expectancy for a 65-year-old man is another 17.6 years. But average healthy life expectancy for that man is only 6.9 years. We can do better than that. A healthier, more productive workforce. Chronic diseases such as hypertension, diabetes, and COPD greatly reduce workforce productivity. The American Diabetes Association estimates the economic cost of diabetes in the US alone at $60 billion per year, from disability, absenteeism, lower productivity, and early death. And of course, the opportunity in jobs and economic across a wide range of fields, including new ones, in science, in R&D, the need for many more researchers in genomics, proteomics, etc. Technology, where entire new fields, such as clinical data mining, managing large healthcare databases, are challenging us. Services, much broader range of healthcare providers than that we have today. Just let me name a few: care pathway managers, genetic counselors, and the like. But equally as there is a bright side, there is a dark side. Most healthcare systems today seem far from capturing these benefits for patients and societies. In all healthcare systems today, there is significant opportunity to improve overall outcome, reduce the variability of these outcomes, and improve productivity. The ratio of outcomes to the cost of delivering them. A couple of examples. Stroke mortality rates in Canada are more than twice those of Norway. COPD admission rates in Germany are more than twice those of France. I have the data. I save you the data. Breast cancer, well known. Mammography rates in high-performing regions in England are twice that of low performers, 85% versus 42%, in the same country with the same healthcare system. But today's focus in most systems is almost exclusively on reducing costs, which almost always means reducing the unit cost of product and services rather than reducing the total cost that is required to achieve the desired outcome, or in other words, improving productivity to the benefit of patients. This approach of reducing costs will not meet the growing demand for healthcare, for quality care, and for outcomes, especially in the context of an aging population. It is unlikely to recognize the value of investing in the revolutionary opportunities facing us. Let me share with you 4 things that I believe policymakers, in practical terms, could do to ensure that society captures these opportunities. First, insist on capturing data on patient outcomes and costs, and use this data to drive decision-making. Many actors in healthcare system have legitimately varying interests, but we share a common interest, improving outcomes for patients and populations. However, most systems today do not measure outcomes and costs for the main diseases. This matters because with these facts, we could take better decisions. We also see that better outcomes are often cheaper. In diabetes, for example, in a US study, the average cost of hospitalization for a poorly controlled patient was $6,800, nearly 2.5 times the $2,800 it costs for a well-controlled patient. Similarly, in a German study, the average annual cost of managing a diabetic patient is €4,500. Only 15% of that is the cost of treating diabetes itself. 35% is the cost of treating complications, and 50% is for their other healthcare problems, which costs more than for the patients without diabetes. We can also find money to save from stopping activities with no or little value as evidenced. In the UK, the Audit Commission found between £250 and £650 million annually could be saved by stopping low-value intervention such as tonsillectomies or other surgeries for patients unlikely to have any functional benefit. Second point, adapt and implement global best practices in key diseases. Kaiser Permanente improved the blood pressure control rate for its diabetic patient from 36% to 77% in a time frame between 2001 and 2008, and saw a 50% reduction in myocardial infarction and 20% reduction in strokes. Canada also improved the control rate for its population from 16 to 66% in a time frame of 10 years, from 1999 to 2006. In Russia, the rate of blood pressure control is only 15 to 20%. We are partnering with the Yaroslav region in Russia to adapt and implement the lessons learned in the US and Canada. And after 18 months, we have rates as high as 50% in the pilot sites. The data will be presented in Toronto later this month. It can be done. Third, be bolder in adopting and carefully experimenting with the new opportunities presented by innovation and technology, even if it means challenging some vested interests. Actually, interestingly enough, much of this innovation is happening in so-called developing countries where there are fewer entrenched incumbents to deal with. As an example, in Mexico, Medical Home uses databases and call center technology to deliver medical advice to patients over the phone, using Cleveland Clinic's protocols to manage common conditions. Of 90,000 calls per month, 2/3 are resolved over the phone, avoiding a clinic or emergency department visit. What can we learn from that? In Bangalore, India, the Narayana Heart Hospital has developed an efficient approach to heart surgery that delivers coronary artery bypass grafts with lower post-op mortality than the US average at a fraction of the cost. What can we learn from that? Companion diagnostic detecting specific characteristics in patients allow the selection of subgroup of patients that will benefit most from a specific drug. Gleevec in oncology is one example. By selecting the right patient for the right drug, we ensure optimal efficacy for patients with optimized cost allocation for society. Fourth, recognize and value the positive contribution of the healthcare industry to the overall economy. Over and above its contribution to patients and population health, healthcare is a source of economic growth and development. It is not just a cost center. I refer you to the incredibly interesting publications of recently, both in France and Switzerland, that have detailed number on this subject. I would like also to attract and direct your attention to an element that is often not recognized enough. The benefits of pharmaceutical innovation to society last far longer than the profit to the innovator. If I take an example of our company, we are losing a patent this year about our antihypertensive ARB, Diovan. Patients and society will continue to benefit from it as long as ARBs remain recommended for hypertension, likely decades, whilst we have only had our part during the patent life. And this is the case with many other disease areas. Compare this with tuberculosis, where we still use the antibiotics from the 50s or earlier, which would not be approved today by the regulators, because the system as it works today simply does not create sufficient incentives to tackle such an urgent problem for patients. In a healthcare system that is focused on improving patient outcomes and system productivity, the cost of delivering these outcomes, there will be many more opportunities for industry and society and many ways for it to contribute to both health and economic well-being. Genuine innovation that improves outcomes or productivity will have a valued place, and the system will have the resources to invest in and pay for it. High-quality generics and self-care products will also have a clear role to play. Whole new businesses can be created around the effective use of information and communication techniques, as well as new categories of rewarding and high-value jobs at varying level of education and experience. Therefore, I strongly believe that industry should engage constructively in policy discussions on the future shape of healthcare systems. We at Novartis look forward to this dialogue, to work with you on this issue so we can capture the exciting area of improvements that lie ahead of us. Thank you very much for your attention.